Good evening, friends and colleagues. This webinar is based on Best of ASH. This will be a 7 days long webinar, as you know, from Monday to Sunday, from 24th to 30th of January. The starting times are a bit different. Today we are beginning now. Tomorrow we'll be beginning a little early at 5:30 and so on. And Sunday, of course, is the whole day, beginning at 10:15 a.m. This webinar is brought to you by Mumbai Hematology Group, managed by Mice Ideas. Today's day one. Our first lecture is on thalassemia by Dr. Ali Taher from Lebanon, and I'll introduce him a little later. This lecture is supported by Sun Pharma. I thank Mr. Arvind Suri and the team from Sun Oncology, Mr. Rajesh, Mr. Kalpesh and the team from Mice Ideas for managing the show, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Tali Aher from Lebanon, and Dr. Richard Silver later on from US. All our discussants who are themselves eminent hematologists, pediatric hematologists, and hemato-oncologists, new participants for sparing a Monday evening. Our discussants today include a galaxy of stars from India from various parts. And to introduce them, we have Dr. Tulika Sheth, Professor, Department of Hematology, AIIMS, New Delhi. Dr. Amita Mahajan, Senior Consultant, Pediatric Hematology, Oncology, Indraprasth Apollo Hospital, New Delhi. Dr. J.M. Khunga, Consultant Professor and HOD, Department of Hematology at Vardhaman Mahavir Medical College, Safdarjung Hospital, New Delhi. Dr. Jina Bhattacharya, Professor, Department of Clinical Hematology, Guwahati Medical College and Hospital, Guwahati. Dr. Joseph John, Professor, Department of Clinical Hematology at CMC, Ludhiana. Colonel Dr. Rajan Kapoor, Professor, Department of Medicine, Consultant Hematologist, Command Hospital, Eastern Command, Kolkata. Dr. Hasmukh Balar, Hematologist and Transplant Physician, Surat Hematology Center, Kiran Hospital, Surat. Dr. Deepak Lad from Department of Clinical Hematology and Medical Oncology at PGI, Chandigarh. Dr. Aditya Jandial, also from the same department. Dr. Richa Jain from Pediatric Hematology Oncology, Department of Pediatrics, PGI, Chandigarh. Dr. Ankita Sen from Emory Hospital, Salt Lake, Kolkata. And Dr. Chandrakant Lahane, BMT Physician Hematologist from Sahyadri Super Specialty Hospital, Pune. It's my pleasure to introduce our chief guest of the day, Brigadier Dr. Tathagata Chatterjee. He's currently Senior Consultant Pathologist and Hematologist, Professor of Hematology and Pathology, Head Clinical and Lab SVS and Dean Academics, ESIC Medical College and Hospital, Faridabad, Haryana. He's former Professor and Head Army Hospital, RNR, Delhi and AFMC Pune. He's alumnus of AFMC Pune and AIIMS New Delhi. He's the first DM Hematopathology from AIIMS New Delhi. Trained in Oncopathology from TMH Mumbai and MRD and Flow from St. Jude Children's Cancer Research Hospital, US. He's awarded FNAMS, FUICC, FISHTM. He was postgraduate teacher in numerous universities in the country and DM examiner at PGI Chandigarh and AIIMS New Delhi. It's over 160 publications, 1,000 citation, H-index 18. Thank you very much for giving this opportunity to me to introduce today's webinar to you. And I request our chief guest to address us and inaugurate today's webinar.
Good evening, ladies and gentlemen, and thank you, Professor Agarwal, sir, for giving me this honor to be the chief guest on day one of your ASH highlights. It's indeed an honor because when I trace my journey, it all started from the Dr. B Agarwal conference and Hematology Today, what we used to attend way back in the 90s. I was then a budding oncopathologist, having trained under Dr. Anita Borges, and I had already done 6 to 7 years in oncopathology when I first met Dr. B Agarwal. And then my career took a turn and I came to hematopathology. And as luck would have it, the DM program also started somewhere in the early 2000s. And that is where I met Dr. Renu Saxena, who was professor of hematology that time and later on became the head of the department. And she was my guide and my mentor. And she introduced me to hematology the way no one else did. She took me to the wards. She introduced me to the patients. And here was a pathologist seeing patients and then coming back and seeing slides. A whole new world started in front of me. Whereas a pathologist, I was told to be proud of my MBBS degree, that look here, son, you're first a physician and then a pathologist. So that's my message to my younger colleagues, if I may give you this advice, that be proud of your MBBS, go to the wards, go to the OPDs, hold the hands and the shoulders of your clinician friends. And that's what we did at AIIMS, New Delhi, when I was doing my DM program. We used to all see the patients have coffee, turbulent round, we used to, there was no question of errors. And then, we used to come back and sit on the deca head and, discuss all our cases together. And at the end of the day, we spoke the same language. The pathologist and the clinicians, we spoke the same language. And who benefited? Of course, we benefited with the knowledge, but the final beneficiary was the patient. And that is exactly what this program at All Institute of Medical Sciences taught me. But I must confess, it all started at Bombay Hospital, where I was first introduced to Dr. B Agarwal. I still remember those beautiful vegetarian lunch we used to have just, after those program. And we used to sit on the floor, literally on the floor, and listen to various, talks about hematology. So I end my topic, a little bit of address, as you said, by thanking Dr. M. B. Agarwal, Dr. Renu Saxena, who is here in the panel. And my advice finally to all of you is, see the patient, come back, see your slides. You will not only be a better pathologist, I think you'll be a better human being also. Thank you.
Thank you, Brigadier Tathagata, for all those kind words and for sparing your time and inaugurating our webinar this evening. I'm grateful to you for sparing your valuable time for us. Now it's time to introduce our guest speaker, Dr. Ali Taher. He's already with us. All of you know him. He has been our regular speaker on multiple occasions. He was in Mumbai as well. And during the pandemic, he has addressed us to update us with the knowledge in the field of thalassemia repeatedly. His formal introduction is Professor of Medicine, Hematology, and Oncology. His director, Neve K. Basil Cancer Institute. His Vice Chair, Research Department of Internal Medicine. Funding Director, Fellowship and Residence Research Program, Faculty of Medicine. American University of Beirut Medical Center, Beirut, Lebanon. Is Professor of Hematology and Medical Oncology, Emory School of Medicine, Atlanta, US. So, sir, welcome to this webinar, and I request you to start your lecture.
Thank you very much for this introduction. It's always a pleasure to be in this meeting with you. Next year, after the COVID and all these issues, I will be able to be with you in the meeting. So I was asked to talk about beta thalassemia. I'll try to cover all issues related to beta thalassemia and try to end by some new ways in treating beta thalassemia. I know some of the things that I might talk about might not be available to each and every. However, the purpose of this presentation is an update rather than a practical way. We could keep the practical questions when we do the questions and answers. This is my disclosure. So the presentation will be a 45 minutes presentation, would be divided into the classification and the modern understanding of the disease, the evidence-based of conventional therapy from transfusion and chelation, and some data on the novel therapies and some of the emerging concepts. So in the classification and the modern disease understanding, I will be going from the molecular understanding, genotype, phenotype, to issues related to patients that are not transfusion dependent and then patients that are transfusion dependent. We all know that the major problem in beta thalassemia is the imbalance between the alpha and beta chain. This imbalance would lead to accumulation of excess unstable cytotoxic alpha globin tetramers on the red blood cell, which will lead to ineffective erythropoiesis, leading to anemia, and this anemia would lead to an increase in absorption of iron together with transfusion, leading to iron overload. So as simple as this is the main pathophysiology of what we are going to talk about. However, sometimes we have some modifiers of severity. The beta mutation might be mild, there might be a co-inheritance of alpha, there might be more effective synthesis of the gamma globin, and all of these would lead to a milder disease. So our conventional way to look into beta thalassemia was to look into the genotype, then the conventional phenotype, and related to the clinical presentation. So from a beta to beta, what we used to call a carrier, to beta 0, which is the beta thalassemia major, and where the patient starts transfusion as early as possible. This is related to severe anemia, splenomegaly, and lifelong transfusion. And in between, we had the beta thalassemia intermedia, where there is delayed or no need to transfusion with mild to moderate anemia and clinical symptoms. So that was the conventional way to look into the disease and its clinical presentation. Most of the slides that I will be using is from our recent publication in New England Journal of Medicine, which was published now in at the end of 2020. But now, the way to look at this is to look into the transfusion requirement and to try to distinguish the major phenotypes, calling them TDT and NTDT. This classification allowed us to standardize research as well as clinical management based on the transfusion requirement of our patient, which is the key driver of our pathophysiology of this disease. It also recognized that severe morbidity can be observed not only in thalassemia major, but also in thalassemia intermedia. And also the international management guidelines have been developed now for TDT and NTDT separately, and these are the TIF guidelines. So if you look into this arrow at one end, you have what we used to call the thalassemia major, and now we call TDT or transfusion-dependent thalassemia. One of them is beta thalassemia major, severe hemoglobin E beta, and hemoglobin BARTs. These require continuous lifelong transfusion for survival. You have the carrier at another end, and in between, you have the non-transfusion dependent thalassemia, or what we used to call thalassemia intermedia. It includes beta thalassemia intermedia, moderate hemoglobin E beta, and hemoglobin H disease. This is a group of patients that do not require continuous blood transfusion for survival. However, they might require it for growth during once they get old because of some complications, if they need surgery, pregnancy, or any infection. So from the genotype phenotypic way to TDT and NTDT that I will be using through this presentation. And this is a slide that I got from our recent publication showing you the genotype, conventional phenotype, clinical presentation, dependence on transfusion, TDT versus NTDT. Before I move to another idea, I just want to say that now we need to clarify further what we need by NTDT and TDT, because some of our patients are getting older, for example, the NTDT patients, and they might require at a certain period in their life continuous blood transfusion. And some have moved into some of the modern therapies, the novel therapies, and have changed to reduction in their transfusion. So one should be critical when using these terminology, and these terminology are very important because they would help us, as I said at the beginning, for our clinical trials using more and more the novel therapies. What about the epidemiology? More we know that more and more we know that there is a epidemiology of beta thalassemia, and this is due to population migration, which has introduced thalassemia into Europe and USA. I will not talk about the diagnosis, which is very well known to you, but it all starts with a good medical history, family history, and a good complete blood count. Let me now move into the pathogenesis in this group of patients in the absence of transfusion and highlight the ineffective erythropoiesis and anemia. As we all know, as I said, it starts with an alpha to beta, leading to ineffective erythropoiesis. The ineffective erythropoiesis would lead to hemolysis, that would lead to hypercoagulability, anemia, and primary iron overload. And you could see all the green lines relating to the worsening of the disease. So if you stop ineffective erythropoiesis, hemolysis, if you treat anemia, then this will improve in our patient. This is what we see in an anti-DT that are not transfused. And this is why it all started with our clinical observation between Lebanon and Italy, where we noticed that in an anti-DT, there are certain complications that we do not see in a TDT, like pulmonary hypertension, extramedullary hematopoiesis, venous thrombosis, silent brain infarcts, and leg ulcers. And when I say anti-DT versus TDT, I mean those TDT that are very well transfused, keeping a pre-hemoglobin level of 9.5 or 10. Because if they are not well transfused, then they will behave like an anti-DT. And all the studies at that time, we did the optimal care study on 600 patients in several parts of our area here, including Milan and Iran. And we showed that higher morbidity rate were confirmed, the complications were confirmed, and there are not any more case reports, and most of them started after the age of 10 years. Of ineffective erythropoiesis correlated very well with the clinical morbidity of anti-DT. And here I'm talking about ineffective erythropoiesis, which is clear in this group of patients as they are not being transfused, and we are not withholding the ineffective erythropoiesis by transfusion. And we know that GDF-15 being ineffective erythropoiesis is related with the clinical severity of the disease. And a very important concept, which relates also to therapy and the new novel therapies we are using, is anemia in this group. And a hemoglobin less than 7 in this group of patients that are not transfused is associated with multiple morbidities, and more than or equal to 10 is associated with no morbidities. And recently we have published in the Annals of Hematology that morbidity-free survival versus multiple morbidity-free survival, once the hemoglobin in the green line is above 10, you would see that the survival and the morbidity is much better than those that has a hemoglobin. So this number of 10 is really very important. It is through which the authorities are approving the new therapies, mainly luspatercept, in the treatment of these patients. And also we have shown clearly that variations of 1 gram per deciliter in hemoglobin versus morbidity, meaning that an increase of a hemoglobin of 1 gram per deciliter reduces markedly the morbidities. And that was a primary outcome in the therapies and the trials of. This ineffective erythropoiesis would lead, and anemia would lead to several complications, which is extramedullary hematopoiesis in any organ, among which is leg ulcers, which is common in those patients that we are not transfused. So now ineffective erythropoiesis and anemia, as I have shown you, if you don't transfuse the patient, this would lead to multiple morbidities. And one of the most important morbidities in the absence of transfusion is overload. So these patients, despite being not transfused, would lead ineffective erythropoiesis, anemia, hypoxia, would lead to a reduction in hep, lead to increased iron overload. So these patients, even if they are not transfused at all, they would have iron overload. And this has been validated through the R2 MRI, T2 star MRI, validated very well among a liver iron concentration from a liver biopsy. So the modality to be used is an LIC through the MRI. And what is important who are not transfused and iron overload is that iron overload is a major contributor not only to iron in the liver, but it is an important to multiple morbidity that goes way beyond the liver. It is proteinuria, end-stage renal disease, hepatic fibrosis, cirrhosis, hepatocellular carcinoma, silent brain infarcts, and pulmonary hypertensions. And we have shown this clearly from our studies, the optimal care that the Orient that I will introduce later, and other local and regional collaborative studies. So iron overload occurs in those patients that are not transfused and lead to certain complications even out of the liver. Also, defining iron overload thresholds in NTDT versus TDT was very important. And now we're talking about those that are not transfused, which is the NTDT. We know clearly from the first on the left that serum ferritin is not really a good marker in the TI or NTDT, and it underestimates the amount of liver iron concentration in an NTDT. And what about countries where MRI is not available and where we don't use an LIC? Serum ferritin above 800 is associated with multiple morbidities. And if you use a liver iron concentration, an LIC above 5. So by now I have introduced complications in a no transfusion patients occur after the age of 10 with a serum ferritin more than 800 and with an LIC above 5. And these are important because this is how the authorities approved chelation in these group of patients. Once again, still, I talked about pathogenesis in the absence of transfusion leading to ineffective erythropoiesis and anemia, and showed you the complications, leading to iron overload and showing you the complications. And the third important thing in the pathogenesis in the absence of transfusion is hypercoagulability. We know that hypercoagulability is present both in TDT and NTDT. However, it is more present in an NTDT. And this is mostly due to several factors. Platelet abnormality, endothelial injury, iron overload. But the most important thing is the pathologic red blood cells that act per se as thrombin generator and lead to thrombosis because of what we call a flip-flop mechanism that occurs on the red blood cell, leading to the serine that will make the red blood cell itself behaves as thrombin generation and lead to thrombosis. And in one of the studies on 8,000 patients that we published in 2006, we showed that this is more common in beta thalassemia intermedia, what we call now NTDT. And we also showed that there are more silent brain infarcts in this group of patients that are not transfused. And this has been duplicated in several studies in Italy, Iran, Lebanon, and USA. So these patients will have increase in thrombin generation and thrombotic events. And this is really very important because when we as adult hematologists are consulted on these patients and they need to do any procedure, surgery, if they have severe infection, an NTDT woman who is pregnant, we need also always to look into the characteristics, being a TI, beta TI, being adult, splenectomized, high platelets, other morbidities. These will all make this patient at a high risk of thrombosis and should be treated as a medically ill patient and should receive prophylactic anticoagulation. And this is why we created and developed this thalassemia-related thrombosis risking score. And if you look at the score, the most score in it is splenectomy. So splenectomy that we used to think at one time that it is good for our NTDT patient, it shows to be very, and it is correlated with almost all the morbidities that we see in our patients, including pulmonary hypertension, which in the Webthal trial, the Italian trial, have shown to be by far more in the NTDT and by far more in those NTDT that gets older and are splenectomized. All of these are characteristics that one should keep in mind when dealing and personalizing treatment in this group of patients. So splenectomy, once commonly performed of patients specifically in NTDT, is now mainly becoming obsolete and reserved only to symptomatic splenomegaly or hypersplenism due to associated infections and thrombosis and due to several other complications. So once again, going back into our pathophysiology, as I said, worsen the disease, the blue line ameliorates. So these patients, because of ineffective erythropoiesis, is leading to all of these complications. And the interaction risk factors would lead to the morbidity in this group of patients. And I have started with the ineffective erythropoiesis, the orange, and anemia, then talked about the iron of splenectomy. All of these will interact together to produce most of the morbidities in an NTDT. So I started by talking about the pathogenesis in an NTDT in those that are not transfused. Now, what about the pathogenesis in those that are transfused? Once again, to our diagram, and you will clearly show here that the transfusion will ameliorate the complications, and as a result would lead to a reduction in ineffective erythropoiesis and a reduction in anemia. I think the blue is not very clear, but whatever is not green ameliorates. So once you transfuse the ameliorate the ineffective and the anemia, and you will remove most of the complications that I have shown you previously in those that are not transfused. But as a result, these patients will get what we call secondary iron overload from transfusion. Transfusion would lead to deposition of iron, transferrin will be saturated, and what would remain out of in the circulation is the non-transferrin bound iron. That would lead to deposition in all the organs of the body, but they will not deposit equally in the organs of the body. And as a result, the patient will get iron overload. And once the liver is full of iron, this would move to the heart. And for sure, all the endocrine organs will have iron deposition. Similar to the thresholds that I have shown you in those that are non of 800 there and an LIC of 5. The studies here are really very old, and they goes back to the 90s when from the public looking into an LIC above 5 in TDT associated with almost all morbidities, above 15, high mortality and severe heart disease and hepatocellular carcinoma. When you look into the heart, it needs to start less than 2, increased cardiac arrhythmia, less than 10, increased heart failure and death. So these are also thresholds for the heart and the liver, but I do believe that the liver should be revisited and also should be by far lower than the numbers we are looking at. And when we talk about morbidity, it is not only in the complications these patients see, but also we have a lot of mental complications in our patients, psychological issues, mostly in the NTDT patients. So the first part was I classified, looked into the pathophysiology, showed you the complications that occurs in those that are non-transfused and the complications that occur in the transfused. Most of the complications in the transfused are related to iron deposition. In the non-transfused, mostly are related to ineffective erythropoiesis, anemia, hemolysis, as well as iron overload. Let's look very briefly also into the conventional therapy or the evidence of base conventional therapy. Once again, back slide showing you that I have showed you previously that transfusion ameliorates ineffective erythropoiesis and anemia in a TDT. Not only this, also iron chelation therapy will ameliorate the secondary iron overload. So for an NTDT, we know that ineffective erythropoiesis there. For a TDT, once you transfuse them properly, you ameliorate ineffective erythropoiesis, you ameliorate anemia, but you get iron overload. And if you chelate them well, you ameliorate the iron overload. We all know that there is a very good relation between transfusion and suppression of ineffective erythropoiesis. So once you transfuse these patients at a hemoglobin, keeping it pre-hemoglobin transfusion of 10, you ameliorate completely ineffective erythropoiesis. And this is why we have all these standards. I will not go through the details, but transfusing our patients every 2 to 5 weeks, keeping a pre-hemoglobin level of 9 to 10.5, and this slide should be updated because now we have the new guidelines that are published, 2021 TIF guidelines. But transfusion comes at a rate, and there are some adverse events for the transfusion. Most common are infection, alloimmunization, and iron overload. And we know that for iron overload, we need to monitor the patients and look into them regularly. So a serum ferritin is important, and T2 star MRI of the heart is important, and a liver iron concentration is important. However, these are not available all over the world. And this is a project that I have done with my colleague Vip Viprakasid, where we looked into areas or resources of liver and suggested, if the MRI is not available, to look into the serum ferritin and to chelate our patient depending on serum ferritin. There is still a lot of variations in iron overload all over the world. And if you see the Middle East, the Far East are by far worse in having more LIC above 15 and more T2 star less than 20 and less than 10. And we all know that our aims of chelation therapy is to prevent iron overload from what we are giving, is to rescue the excess iron that already the patients have. And sometimes to emergency is needed intense chelation, for example, prior to bone marrow transplant in a pregnant woman, patients with heart failure. We know that we have 3 chelators available in the market, the spheroxamine and Deferazirox. I can keep the discussion for the questions if needed. We lack a large head-to-head comparison between the oral chelators. Despite having all these oral chelators, still we have barriers to adherence in iron chelation therapy. And even with the presence of a chelator that is given once, we still have adherence issues in our patients. And our adherence issues are because early iron overload is asymptomatic. Administration of chelation sometimes is inconvenient, it has side effects. Patient does not feel better when you chelate them because sometimes they cannot feel that they are better. And a major issue is transition from pediatric to adulthood is really very important. Adherence, as I said, then is a major problem. Patients forget their treatment and they do not always adhere to therapy. And this is why now we have the Deferazirox, the film-coated tablet, and that was approved through the ECLIPSE trial, where it shows clearly that those patients with a tablet that is not dispersible and they can take the tablet or they can crush it and put it on food, they had better adherence, better satisfaction, better preference, and better results. So I showed you that in transfusion, iron deposition would lead to complications, and iron therapy is really needed. And this iron therapy, since we know by now that improved survival, very clear from cow old trial, and you could see very clearly the more we transfused our patients, the better survival. The more we chelated our patients, the better survival from Brittingham study. The more we started to use an MRI, the less the cardiac complications and the mortality of our patient changed. And this is why currently we're seeing new morbidities in our patients, whether in Cyprus, in Thailand, or in our part of the world, and I'm sure in your part of the world, trends in mortality and morbidity are changing. And this is why we have now novel therapies that are gradually being integrated into our system. And this is a slide that I have cut from my journal in the New England Journal of Medicine, and also has been introduced in the TIF guidelines. So the management of those that are not transfused into the hemoglobin. If the hemoglobin is low, then these patients might be eligible into one of the new trials. If the hemoglobin, if you do not have any possibility of introducing into a clinical trial, it should be tailored, and the patients should receive transfusion whenever needed. For an anti-DT, chelation should be done if the serum ferritin is above 800, and if the patient have an of 5. The anti-DT will be transfused if there is an infection, pregnancy, for growth, and for some complications. And we very well know from the trial of Vipbracacid that these patients might require transfusing during adolescence for better growth, and then at a later decrease the transfusion or stop the transfusion. And from the optimal, know very well that those patients that were well transfused whenever needed as an anti-DT had less complications. So we know by now that transfusion might ameliorate the ineffective erythropoiesis and lead to less complications. These are some of the new studies that we have published or end of last year. And this is a very large study that shows you the survival in 2,033 patients of anti-DT in a very large group of study. That shows you clearly that the mortality is changing in this patients, and that those patients that are regularly transfused have a better survival and less mortality from cardiovascular disease, and shows you that the cardiovascular disease in this group of patients is mostly pulmonary hypertension. These are the guidelines for the anti-DT that I have discussed with you. Above the age of 10, ferritin above 800, above 5 should be chelated. And by now we know that the Thalassemia study is the study through which the FDA approved the chelation of this was reaching 20 milligram per kilogram per day. And recently, hopefully we will publish our 5-year data showing the safety also in increasing the dose in this group of patients, 30 milligram per kilogram per day. Also, reduction in liver-related mortality in an anti was seen clearly in those that were chelated well. So better chelated, less mortality in an anti-DT because we used not to chelate these patients. So our care should be a holistic care in our patients. And this is why I would advise all of you who are interested, especially the junior people, to read this New England or the Lancet one 2 years ago, or the Blood one that was mainly targeted to how to manage medical complications in beta thalassemia that are getting older. Our patients are getting older and they are moving into adulthood and they are having more complications. So growth failure, poor development, skeletal development, sexual development are not only the problems that we see. Pregnancy, malignancy, workplace and financial duties, marriage, family duties, and survival stress is really becoming very important in this group of patients. And before I end, introduce some of the modern therapies. As I said, I know that these might not be applicable for some parts of the world, but however, it's worth introducing them. So the novel therapies that have been recently or will be currently considered in beta thalassemia as shown in this slide. So the imbalance of alpha to beta would lead to gene, and this is gene therapy. I will not be discussing this. Also, there we have some iron affecting iron overload by using some hepcidin mimetics. I will be concentrating mostly on targeting ineffective erythropoiesis through the luspatercept that has been. So if you see, when I started with the pathophysiology, the imbalance of alpha to beta will be targeted by gene therapy, gene editing, hemoglobin F inducing agent. The ineffective erythropoiesis will be targeted by erythroid maturating agents and other, and the low hepcidin level will be targeted by the hepcidin mimetics. And this is the novel way into looking into the new therapies. So what is luspatercept? Is the first-in-class erythroid maturating agent that neutralizes select TGF, beta superfamily Leiden, and enhanced erythropoiesis. I will go directly into the BELIEVE trial, which is a randomized, double-blind, placebo-controlled phase 3 study through which the FDA and the EMEA has approved it in TDT patient. The study randomized luspatercept 1 milligram per kilogram every 21 days, and it might be titrated into 1.25 versus a placebo. These patients were followed for 1 year, and now they're being followed up for 5 years. And it clearly showed a significant greater proportion of luspatercept treated patients achieved more than 33% reduction. So the purpose in this study was to reduce the transfusing burden. And a significantly greater proportion of the luspatercept related patients achieved meaningful reduction, more than 50%. It was safe. We could keep this third question. No thrombosis, no death. Luspatercept then has been approved in 2019 by the FDA, and 2020 it's being approved now in other parts of the world. That was in the TDT. In the NTDT, I'm leading this trial. Hopefully will be published very soon. The year 1 is closed and the patients are moving into year 2 and will be into the long-term follow-up. The primary endpoint here is different, not reduction in transfusion because they are not transfused, is to increase in the hemoglobin level. And the secondary outcome is to look at and weakness as a patient-reported outcome. 77% of the patient in the luspatercept arm versus 0% achieved an increase in hemoglobin of 1. And when we looked into between week 13 to 20, around 50% increased their hemoglobin above 1.5. This all relates to what I've presented at the beginning, showing you that an increase in 1 and 1.5 is associated with less mortality and morbidity in this group of patients. Not only this, all those patients that increased their hemoglobin had a better improvement in their patient-reported outcome, quality of life, and specifically in the tiredness and weakness domain. And hopefully, we have introduced luspatercept into the new TIF guidelines, and for TDT, hopefully for NTDT, the path forward for NTDT will use it into the guidelines, and for sure we'll be having more and more studies, maybe combination therapy. So because we know that first NTDT had no intervention, which is the left up, then we moved into iron chelation therapy, sometimes transfusion, then we did the luspatercept, and now we're doing the mitapivat trial, and hopefully maybe combination therapy. All of these will come at an expense. Despite discussing all these novel therapy, I do believe that still good chelation therapy, good transfusion, personalizing treatment is the most important for our patients. Thank you.
Thank you so much, sir. That was fantastic for updating us in both TDT and NTDT. A lot of our colleagues are here who will be interested in asking some difficulties and questions. We'll be using the raise hand sign. Until that happens, I'll ask some question from the audience. We have Dr. Aditi Shah. She wants to know, can D-ferricirox also cause neutropenia?
To my knowledge, D-ferricirox has not produced neutropenia in any of the thalassemia patients. Maybe because, as you know, it is used in myelodysplastic syndrome in the MDS, and some of these are at a higher risk, or some of them is part of their disease. But I mean, neutropenia is not our concern in the ferrous.
Right, sir. Dr. Amita Mahajan, your question.
Thank you, Dr. Taher, for a wonderful presentation. My question is about transfusion thresholds in NTDT. The conventional teaching has been that we should never use the hemoglobin level alone for decision making. But considering the vast body of literature and your own work, which shows that long-term morbidity is much higher when lower lower hemoglobins are accepted, do you think it's time to revisit how we manage NTDT in terms of transfusion?
Yes, sure. And this is why I ended by saying that we need to personalize the treatment, because, you know, some of them had a high hemoglobin. Let's say some NTDT had severe ineffective erythropoiesis, yet they have a high hemoglobin. These might need transfusion because this might lead to some complications. Some of them are growing very well at a hemoglobin of 8.5 and had no complication. So despite what I'm showing, I think that in NTDT, we still need to personalize and discuss. Keeping in mind that once we start using the novel therapies, we might try to improve. But I'm not advocating transfusing the patients. I'm showing that we need, although I would say that for growth, probably not to have all these facial deformities and growth problems and cognitive issues at school, I will advocate transfusing them, increasing their hemoglobin for a better growth. For a pregnant woman, for example, to decrease thrombosis. So this is why I say in an NTDT, let's look at it holistically and look at all these issues and decide until, which I don't think will happen, have a major trial that would look into all these issues. But now with more and more getting into all these novel therapies, I think we will probably, the hemoglobin will be increased without transfusion.
Thank you. Thank you.
Thank you, sir. Continuing with Amita's question, if a patient of NTDT is started on transfusion, and if these novel agents are not going to be available soon, do they have to remain on the transfusion for the rest of their life? Or there are some who can get rid of it?
No, it depends why you are transfusing them. If you are transfusing them for growth, they will take it during their growth, then we'll give them a trial. If you are transfusing them for a leg ulcer, then you will stop when the ulcer closes. If you are transfusing them for severe pulmonary hypertension, for example, you would keep them on to prevent the pulmonary together with other needed treatment for pulmonary hypertension. So it all depends on the introduce hydroxyurea, transfuse, decrease the morbidity, introduce hydroxyurea, and remove the transfusion. So I think we need to, as I answered Amita, personalize even in transfusion. For transfusion in an NTDT needs to be personalized. It's not like the chelation where you just look at the threshold and treat our patient.
Right, sir. Dr. Richa, your question.
Right. Thank you, Professor Taher. My question is regarding iron overload in thalassemia, non-transfusion dependent thalassemias. So my question is twofold. First is like this LIC of 5 gram, how does it correlate to the ferritin of 800? Because we have found in our cohort of adolescents and young adults that this 800 of ferritin value, 800 nanogram ferritin value really misses quite a few iron overloaded patients. And do you think that the cutoff should be slightly lower is one question.
Let me answer this first. Because of time, I was unable to go through the details. First of all, any patient with an NTDT with a serum ferritin of 300 needs no chelation. 300.
Right.
Any patient with 800 needs to be chelated. Any patient between 300 and MRI is much better, because if you use only ferritin, you will miss some patients. But these are very few patients. But I mean, I created that with VIP so that at least we will chelate 80 to 90% of those patients. But for sure, and I fully agree with you, between 500 and 800, you might miss some of the patients. But what I would suggest, if they have any complication, chelate them, even if they are, because at least don't reach 300 or reach 300, and that is safe for you because we have shown safety at 300.
Right. Thank you. My other question was that anemia does not always correlate. The degree of anemia does not necessarily correlate with iron overload. So what are the other genetic modifiers, in your opinion, that lead to iron overload?
I mean, anemia is the most ineffective erythropoiesis and important cause of a reduction in hepcidin and an increase in iron overload in our patients. Now, not all patients, I'm sure there are other iron that might lead to a reduction or more increase in this group of patients, but at least those with a low hepcidin would have an increase in iron overload in this group of patients.
I see. Thank you.
Thank you.
Thank you, Dr. Richa. How do you see the hepcidin analogs coming up in clinical practice?
I mean, I had the slides, but I removed them at the end because I thought for India and for patients where they do not have even sometimes blood transfusion, it's not fair to talk about many hepcidins. We have done, there are 3 or 4 trials running on. 2 were stopped because of no improvement. 2 are still on. We still don't have data. Some of them have a primary outcome, an increase in hemoglobin, and the secondary outcome, a reduction in ferritin, and the others. So until probably mid to end of this year, we will have some data, at least from the V4 trial.
And you just sort of mentioned about the Myeloproliferative trial that you are doing. Any results?
The Myeloproliferative trial, there is the phase 2 was presented at ASH for the early start, which was also similar to the luspatercept, showing an increase in hemoglobin in the anti-DT patients. Now the phase 3 for TDT and anti-DT will be starting in a few weeks, which is the AGIOS trial for AGIOS and energized T, they are called.
Thank you. Dr. Aditya?
Good evening, sir, and thanks a lot for the wonderful talk. So my question is regarding your experience with COVID-19 in anti-DT and TDT. So as you mentioned, the hypercoagulability is an important component of overall pathogenesis of anti-DT. So what is your overall experience with the thrombotic events, and have you changed your policy regarding thromboprophylaxis or aspirin while dealing with such patients or vaccinating such patients?
I mean, we had reported our, I think before the Omicron, at least in the beginning, we have looked into 35 or 40 patients of our patients. Thalassemia, the outcome was the same in TDT and anti-DT, and we did not lose any patients, and they were not really very probably realized. But for your question, an anti-DT who is admitted to the hospital, specifically if splenectomized with a high D-dimers and severe COVID, should receive anticoagulation high-risk patient for sure. Vaccination, all of them are we are vaccinating. We're advocating vaccinating all our patients. Nice
Thank
question.
You, sir.
Thank you. We'll take one question from the audience. There's a question related to thalidomide and lenalidomide. Are they useful in extramedullary hematopoiesis in anti-DT? Is there any?
There are some cases, as you know, these are toxic products that we use for myeloma. There are some case reports on this. Some of these case reports comes from India, some from Italy, on some patients that were unable to cross-match and transfuse a TDT. I mean, these are unsafe, not unsafe, they have some adverse events. So I don't think a clinical trial, maybe they will be used out of the concept with the approval of the patient if there is no other way to treat the patient.
Thank you. Hasmukh, your question.
Thank you, Dr. Taher, for such an informative lecture. I would like to know your approach for alloimmunization in TDT, management of alloimmunization in TDT.
Now, the alloimmunization is really mostly seen in anti-DT more than in a TDT. You know, in an anti-DT, when they are not transfused at all, and you transfuse them suddenly at the in adolescent or adulthood, the risk of alloimmunization is much higher. We do not have a major issue in alloimmunization. Usually this is taken care by the transfusionist at the center. We do cross-match for everything for our patients. Once they develop alloimmunization, steroids as given, and sometimes rituximab to reduce. Ideally, the patients that can be admitted into either luspatercept in a clinical trial or luspatercept in the ideal, if you are unable to use a safe and efficacious blood unit for them.
Okay, thank you.
One more question from the audience is related to, if you develop deferricirox induced kidney problem, then how do you proceed with their chelation? Is the drug out?
If you produce severe, then use another chelator. Yeah, I mean, it's as simple as possible. Now we have a menu. So why should you give some? I mean, at least in my opinion, I'll use another chelator for sure.
Right.
As simple as possible.
Yeah, Dr. Shruti, your question.
Good evening, sir, and thank you for that brief overview of management of thalassemia. And my question is actually quite similar to Dr. Hasmukh's question, and this is regarding a 16-year-old boy who we saw for the first time at the age of 12, adolescence, as you said, was being managed as NTDT, no transfusion, but the patient came to us with splenomegaly about 13-14 centimeters below the costal margin and non-healing leg ulcers. We started transfusion, were able to maintain, HB 9.5, 10 for a couple of years, and then the alloimmunization kicked in. Although we try to do, extended phenotype most of the times, but sometimes, lack of kit, lack of machinery, something goes off and it is not possible. So now, in spite of doing whatever is possible, we are not able to move on beyond the HB of about 7.58, and that leg ulcer has reappeared. So how would you help us deal with this patient?
I will suggest use. Is he on hydroxyurea?
He was on hydroxyurea, but with that leg ulcer repairing, we had this doubt whether it is because of hydroxyurea. We stopped it for some time.
If I will reintroduce, because the ulcer might be due to hydroxyurea. All the reported cases of leg ulcers were not on hydroxyurea, but I fully agree with you that the ulcer might be due to hydroxyurea. I will reinitiate hydroxyurea because now for him to close his ulcer, I would, if soon luspatercept also is available, then this would be an ideal patient. Give luspatercept after the approval of the Beyond, because it can close the ulcer, it can raise the hemoglobin, and we can get. But I will suggest now, in the meantime, to start on. It will be of benefit to this patient for sure.
Thank you.
Thank you, sir. Just one point, like you were mentioning rituximab versus steroids for alloimmunization. Ritux is quite expensive and most of our patients are not able to afford it. So what would be the schedule of steroids, dose and duration that you would recommend for such a patient?
There isn't any schedule. It's you could use 1 milligram per kilogram per day and start to reduce. There isn't any single schedule because each center does what is. But I agree with you, and this is why for your patient, for example, I said hydroxyurea for the ulcer and for the alloimmunization, because I know that rituximab, but I don't think that 4 doses of rituximab is very expensive compared to if you do cost effectiveness with transfusion and the complication and the rituximab. So because we're using it sometimes in severe malignant hematology cases of outcome or survival, yet this can benefit your patient. So I'm sure if we negotiate on it, that would be also another alternative for your patient.
Thank you, sir.
Thank you, Shruti. One more question from the audience is related to MRI showing pancreatic iron overload. How do you interpret and manage?
with all my respect, I don't do pancreatic iron overload. It's too sophisticated for me now. But I mean, the only people that do pancreatic iron overload is the US people, where they try to look into their T2 star MRI and look into. I mean, we could barely do T2 star of all our patients who are out of clinical trials. So I don't think we will. But I mean, if the doctor who asked me is doing a T2 star for all his sophisticated T2 star and reading, could detect the pancreatic T2 star. I suggest chelating our patients very early, whenever needed, to prevent endocrine problems, rather than waiting and looking into iron overload, which John Woods, as you know, keeps on mentioning in his papers. Let's look into the iron in the liver and heart, which are very important for us, and move from there.
Yeah, in India, we automatically get the report of pancreatic without any extra expenses. Therefore, this question comes up. Sometimes liver and heart are okay, but pancreatic.
I think it's associated with more pituitary the iron, and then it relates. So, I mean, but the whole, I mean, to be what do you call it? To be practical, it all relates to chelating this patient very well at all levels.
Sure. Yes, Dr. Mukul, your question.
Thank you, Dr. Taher, for the excellent talk and very good reply to all the questions. So my question is a very basic one. This is regarding thalassemia intermedia and sickle cell anemia, who almost all of us put on hydroxyurea. And some of them respond, some do not respond with rising hemoglobin, and they are ultimately put on a transfusion program. So is it beneficial to continue hydroxyurea in such patients with the transfusion program, or we can stop hydroxyurea altogether, considering the the extra hematopoietic benefits of hydroxyurea?
Yeah, I mean, the extra benefit of hydroxyurea and oxymedullary is if they are not transfused. But if you are transfusing your patient continuously, like a TDT being transfused, and you're ameliorating the ineffective erythropoiesis, why to add an extra cost and extra hydroxyurea? Unless you are trying to space your transfusing or use it, but otherwise, if you're transfusing regularly, I don't see any benefit of using hydroxyurea.
Will the use of hydroxyurea lead to increase in the duration of transfusion period in such circumstances?
In my experience, and never. But I mean, the experience in India, as I read, for example, and in Iran, shows that hydroxyurea benefit. But at least in my experience, in our area and in Europe.
Thank you.
Thank you. Dr. Amita?
Dr. Taher, just a practical question. We are now able to manage chelation, well for most of our patients at our center. And if we are predominantly using serum ferritin to guide our, iron overload management, what is the optimal ferritin that we must target for?
I mean,
because the guidelines are a little ambivalent on that, and I think they're, real cautious. I think we could push harder. So, what is the practical cutoff that you would ask our patients to strive towards?
In my opinion, in an NTDT, as I said, 300 is safe. In a TDT, 500 is safe. We know them very well. Now, if you go below 500 in a TDT, as some claims, some muscular disc problems, we might get some. So the safety data is available for an LIC of 3 in both, and for a ferritin 300 in an NTDT and ferritin 500 in a TDT, we have the safety data. Just to be safe and not to, I don't want anyone now to, patients, physicians claim that if you go to a ferritin of 100, you reverse the endocrine. But I'm afraid that these patients might get some other complications.
Thank you. Thank you.
Thank you. There's a question related to erythropoietin and darbepoietin. Is there any place?
I mean, as you know, this has been done by late Rachmilewicz and other in the 80s and early 90s. And for an improvement is you need to use a very, very high dose, which becomes by far more expensive than any of the new novel therapies. And not only this, you might exacerbate ineffective erythropoiesis by stimulating further the bone marrow. And the risk of thrombosis will be higher and you will get more complications. So in my knowledge, I don't think that it is a safe, efficacious way for patients.
Right, sir. Do you see there is any place for ruxolitinib in reducing the spleen if cost is not an issue?
As you know, we have published in Blood our study on ruxolitinib. That trial was done on 30 patients. I did this trial, I remember, with Novartis few years ago. The spleen, but did not improve hemoglobin. On the contrary, it lowered hemoglobin, but it was done on TDT. I tried to convince Novartis to do it on an anti-DT, but they did not, they wanted to stop. So if somebody has a huge spleen and Jakavi is available, then splenectomy, not to get complication, it might be an interesting way to reduce the spleen and move into another, if it is available and can be used.
Dr. Amita?
So just a comment on that, because we published very recently in British Journal of Hematology a limited experience in with ruxolitinib in an attempt to avert splenectomy. There were 2 TDT and two NTDT managed previously at another centers, and we were able to avert splenectomy in them. To just share that, my question was that to my knowledge, Reblozyl is currently licensed for 18 and above. Do you think in the near future, or it may be already be happening, that the licensing will move towards younger patients?
I don't think the licensing, because I mean the approval is mostly for myelofibrosis, which you rarely. I think I'm not sure they will do any trial on it. Maybe
Younger
that
patients.
will be off-label or under, but I don't think it can be done for younger.
Okay, thank you.
Even the toxicity profile is not known for
younger patients. Yeah.
I read your paper also.
Thank you.
One question related to the types of bone marrow transplant. Would you advocate haplotransplants in thalassemia?
To tell you, I'm not really an expert in transplant, but now we do prefer to do the identical. There are few that is done, which is done by my transplant team. The results are, acceptable. However, if you look you would see that there is a good. But in our part of the world where there are a lot of siblings for our patients, I think it's easier to do the regular transplant for our patients.
Another question related to transplant is about anti-DT. If their quality of life is not very good, you will suggest them regular transfusion chelation, or they should go for transplant?
If their quality of life is not good and they are not receiving transfusion and chelation, for sure I will give transfusion and chelation. The issue of transplant in an anti-DT is becoming more philosophical. Predict ahead the complications that they might come, and we have some predictors. Interesting project to work on, then these might be considered for transplant. Even for gene therapy, as you know now, the looking more into the TDT, so it is more philosophical and I think it should be case by case, because older age with all the complications, I don't think see any benefit in transplanting these patients.
Right, sir. You talked about thrombotic score. There's a question that in anti-DT, should you put the patient on at least prophylactic antiplatelet agents?
All my, all my anti-DT patients, non-splenectomized, are on
Antiplatelet agents.
prophylactic, or my TDT patients who are splenectomized are on. We don't have solid data because, in some studies are very simple, like the hydrea studies, the aspirin, yet they are very, we don't have a lot of randomized trials on them, but we have shown that in the large epidemiological study that most of the patients who are on aspirin had less thrombotic events and less silent brain infarcts and less strokes.
The question is about the duration of anticoagulation. If somebody has developed thrombosis, you are anticoagulated, will it continue for lifelong?
Somebody who develops thrombosis as any medically ill patient who needs. So if it is severe, if it is, we should follow up the ACCP or the guidelines that we follow, because these are like any patient.
One question is about anti-DT and bone disease. How do you prevent the bone disease? Will you give bisphosphonates early?
Our thalassemia patients are in a multidisciplinary care center. So immunologist and our bone that will be looking at them. So for those who was asking me this question, I could link you to the specialist and maybe could give you the guidelines that we are using currently for the bone. And at the same time, for you, if you're interested, the chapter that is written in the new TIF book, what was published a few months ago, the 2021 TIF TDT guidelines, there is a chapter on bone written by the expert, I forgot the name, the Greek expert person on bone.
Excellent. The question about in which direction the gene therapy in thalassemia moving?
Looking into the because the beta zero patients are really not doing very well, and we don't want to do a gene therapy and move our patients from a TDT to anti-DT. So still awaiting the long-term studies of the American, the French, and the Italian, and I think time is needed to look into the outcome of these studies, specifically to look into also malignancy and reported some of the question mark on malignancy in this group of patients.
Right. You published an article about bitopertin in thalassemia.
The study was, bitopertin was an interesting product that we thought it might increase hemoglobin. However, it was early because it did not show any benefit, although in mouse models it showed some benefit. That was published with, I think, Carlo Uriana from the American Journal of Hematology. We worked together because the mouse model was very interesting. However, in clinical practice, it did not show any benefit.
Right. One last question that I have is, are your all splenectomized patient on lifelong penicillin prophylaxis, or can it be stopped?
Most of our patients are on 5 years. 5 years prophylaxis.
Right.
This is also a controversial issue.
Any questions from the faculty here? Because that's the last question I have here. If none, then I'm going to hand over to Dr. Poonam Rohira for the official vote of thanks. But on my behalf and behalf of Mumbai Hematology Group, I'm extremely grateful, Dr. Taher, to you. You always obliged us by updating our knowledge.
Thank you very much for inviting me. Thank you very much.
Poonam.
Thank you, Dr. Taher, for sharing your pearls of wisdom on thalassemia. On behalf of Sun Oncology, I take this opportunity to thank Dr. Agarwal and the Mumbai Hematology Group for giving us an opportunity to be associated as friends of the meet for Best of ASH. It is always a pleasure for Sun Oncology to be associated with such academic endeavors. Thank you once again. And sir, over to you now.
Thank you.
Thank you.
So,
Thank
Dr.
you very
Taher, we will keep bothering you in future. Thank you.
I'm available anytime. Thank you very much. It's my pleasure. Hope to see you soon.
Good day.
Bye-bye.
So, friends, thank you very much for being with us for the thalassemia session. We are going to have a break of about 15 minutes, and we come back at 7:55 for the next session on myeloproliferative neoplasm. 7:55. Thank you so much. Good evening, friends. Welcome to the second lecture of the day. Our speaker is Dr. Richard T. Silva, MD, FACP. He's Professor Emeritus of Medicine. Richard T. Silva, MD, Myeloproliferative Neoplasm Center, Well Cornell. Medical Director, Cancer Research and Treatment Fund, New York, US. He's a father figure in the field of myeloproliferative neoplasms. His contribution has been immense. I invite him to give his talk on MPN. Over to you, sir.
Well, good morning in New York and good evening in India. And it is a great privilege and pleasure for me to participate in this scientific meeting. I thank Dr. Agarwal for inviting me, and I'm privileged to join the Mumbai Hematology group for this session. We will be discussing interferon, so I will make some disclosures here. Also, we'll be talking about navitoclax, which is a product of AbbVie, so I am a consultant with AbbVie. And we have multiple other involvement with pharmaceutical companies through clinical trials, but I have no conflict of interest. So I thought to select the topics from the MPN ASH meeting of interest would be some aspects of translational research, review of some important clinical studies, and then make some concluding remarks. I am going to do something a little bit different this morning because I thought that it would be of interest to put these papers and discussions in clinical perspective. So I will be introducing some additional information rather than just giving you a litany of the abstracts that were presented, which I find, I've gone through a session with my own medical school. I find that very uninformative because you just have a lot of information that keeps repeating itself. So I'm going to talk about fewer subjects, but put them more or less in context and perspective, hopefully. So I think one of the most important aspects of hematology is the issue of CHIP, or clonal hematopoiesis of indeterminate potential. And we are familiar with the fact that CHIP is associated with a variety of cardiovascular and presumably hematologic disorders. We recently wrote a paper about CHIP and inflammatory disease in the myeloproliferative neoplasm with my colleague, Dr. Hans Hasselbacher. It's in a recent journal from Europe, which you may wish to check if you like, pertaining to a CHIP in myeloproliferative neoplasms, particularly polycythemia vera. But as it appears in this abstract, what was very interesting was that CHIP seemed to be protective of Alzheimer's disease, which is a variance with the literature in general and most people's experience. But for those of you perhaps not familiar with Stanford, it is a leading medical institution in the United States, not only in medicine, but in other areas. And so we have to pay attention to what this report was. And as you probably know, but for those of you not familiar with CHIP, clonal hematopoiesis of indeterminate potential, or CHIP, is a hematopoietic stem cell phenomenon wherein hematopoietic stem cells acquire a mutation, usually a variant of TET2 or DNMT3A, which are mutations associated with both abnormal cardiovascular disease and, as we'll talk about in just a second, hematologic disorders. But the landmark study from the New England Journal of Medicine showed that CHIP may cause or be associated with atherosclerosis and other inflammatory diseases because this mutation or these mutations alter the function or development of effector immune cells derived from hematopoietic stem cells. Now, what's interesting to us as hematologists is that blood cells may develop from cooperating mutations, particularly JAK2. And as we all know, JAK2, TET2 are very important, not only in the pathogenesis of polycythemia vera, but also myelofibrosis, and less often in ET. So what I was unaware of was the fact that these mutations, DNMTA, TET2, can be found in microglial cells and resident myeloid cells in the central nervous system, and they may be involved in Alzheimer's disease. And genome-wide association studies implicate the microglia and resident myeloid cells in the brains as key in Alzheimer's disease, as you may be familiar with. So CHIP has been associated with Alzheimer's disease, dementia, and neuropathologic change. And these mutant marrow cells could be found in brains of CHIP carriers. However, the Stanford researchers found that reduction of amyloid plaques and neurofibrillar tangles in the brains of those without dementia have also been found. And CHIP was found to be associated with protection from Alzheimer's disease dementia, lower levels of neuritic plaques, and neurofibrillary tangles in those without dementia. So the issue of how much CHIP is associated with the presence of neurofibrillary tangles in those with or without dementia is really an unresolved issue according to the Stanford investigators, but they found that CHIP was associated basically with a reduced number of neurofibrillary tangles and plaques. And furthermore, that CHIP was associated with a reduced risk of Alzheimer's disease dementia, which is at variance, as I said, with many other studies that have preceded it. So that caused a great deal of discussion. And in talking to the experts on this, of which I am not, because I'm not a neurohematologist, I don't even think that specialty exists, but others disagree with this finding, although there was no explanation at the presentation as to why the Stanford investigators found that CHIP was protective and also not associated with Alzheimer's disease and dementia, when other individuals have found this to be so. So this is a very interesting finding, and we have to follow this very carefully. As you know, there is a medication now for Alzheimer's dementia in the United States, manufactured by Biogen, which is the pharmaceutical company. And there's a great deal of discussion and disagreement as to whether or not this should have been approved by our Food and Drug Administration. So Alzheimer's disease is an illness that not only causes dementia, but causes a great deal of argument and discussion as to its proper treatment and pathogenesis. There were more than 300 abstracts relating to P53, which we all know is a suppressor gene in performing hematologic disorders and cancer in general. And it was impossible really to come to a meaningful conclusion other to say that we don't know a great deal about this suppressor gene. So I just summarized it in 2 simple slides because I like takeaway messages. It is located on the short arm of chromosome 17. It encodes a transcription factor which responds to stress by regulating cell cycle arrest, apoptosis, senescence, and DNA repair. And it is the most frequently mutated gene in human malignancies. Unfortunately, as I will mention again in a subsequent PowerPoint slide, there is no significant P53 inhibitors which are practical in clinical medicine for the MPNs as yet, and one MDM2 inhibitor which is involved with P53 inhibition, itis and Nutlin has been found to have too much GI gastrointestinal toxicity to be useful in the clinic, although it has had some effect on P53 effector. Now, I mentioned the fact that P53 is located on the short arm of chromosome 17. And the question comes up in clinical medicine, is cytogenetics still important in hematology? And I believe it is, because when we find an abnormality in chromosome 17 in patients with myeloproliferative disorders, particularly myelofibrosis, or even P50, even in polycythemia vera, we are concerned about the patient and will take extra steps to make sure that next generation sequencing studies have been done appropriately so that we are not missing a patient whose prognosis would be affected by this finding. And as you know, finding abnormalities of chromosome 17 in patients with CML is considered a poor prognostic finding. So the questions regarding P53, which really came out of the meeting, are what are the most important pathways for tumor growth and metastases that are involved in P53 that are still known? Are all P53 mutations of the same significance? We don't really know that for sure. And do different hotspots on the P53 gene have the same significance? And that was really what a lot of the discussion at ASH was about this past year. Now, we all know about a lot of transcription factors that predispose to poor prognosis in the MPNs. And one of the most important ones is in a transcription factor known as FEE2, which Professor Heike Paul from Hanover, Germany has been working on for many, many years. And finally, the clinical significance of this has been found. There was the presentation at ASH was preceded by an article in Blood, which many of you may have read, with a commentary by her, because NFE2 is expressed in hematopoietic stem cells and myeloid precursors. That's been known for many, many years. However, it is overexpressed in a majority of MPN patients. When it is overexpressed in transgenic mice, it gives rise to an MPN phenotype, and 10% of these mice spontaneously transform to acute myeloid leukemia. And it was shown that the effect of NFE2 mutations on overall survival in these transgenic mice was rather significant. The top curve shows the mice without the NFE2 mutation, and the bottom curve to the left shows those with, and as you can see, there is a striking difference. So the clinical take-home points are that NFE2 should be screened during disease course, and particularly as necessary during times of transformation. In the mice, there was a significantly striking hazard ratio in those mice who transformed to acute leukemia, and there was a significant hazard ratio for those who had the transformation with impaired survival compared to those who did not. And multivariate analysis disclosed the fact that this was a poor prognostic sign. And so we should consider this especially in patients who have a poor initial response to treatment and during acceleration or loss of response to treatment. And we have added NFE2, or in the process of doing it, to our NGS panel, the next generation sequencing panel, such as ASXL1, EZH2, et cetera, to search for those mutations that are associated with poor prognosis. Now, the very significant addition to our therapeutic regimens has now been the approval of Rohira, which is a type of interferon, which we'll describe in just a minute, and has been approved in Europe. And I don't know what the situation is in India, but it's certainly will make interferon far more accessible from an insurance standpoint in the United States, because it's now been approved by the Food and Drug Administration. The company that manufactured it is Pharmacentia. In Europe, it had previously been approved by the European Union, manufactured by a company named AOP. And in Europe, more than in the US and Canada, they are using interferons as first-line therapy for the treatment of polycythemia vera, and also in patients with myelofibrosis and some patients with ET. So it's a drug that everybody must become familiar with in its use. As we all know, hydroxyurea, both in the United States, is used in 85% of patients treated with polycythemia vera, far less in Europe, and about 50% of patients in Canada. Hydroxyurea is an easily used medication, and it is inexpensive, but unfortunately does not change the natural history of the disease as interferon does. Now, interferon is also of considerable importance because of the fact that its overexpression probably is the cause of many of the abnormal effects of the COVID virus, and probably is the cause of the mortality that we see, particularly with the Delta variant, because of this overexpression of interferon type 1. Now, it is of interest that about 75 years ago, John Lindemann first discovered interferon working with Isaacs in London, and they noted there was a substance, presumably a virus, that interfered with the subsequent effect of the live virus on the same cell. So this dead product, which then turned out to be in fact a virus, a dead virus, interfered with the subsequent infection of live virus on the same cells, and thus the term interferon. It's of interest that when Dr. Lindemann, who was a Swiss, returned to Switzerland, he did not want to continue studies on interferon alone, but was involved with finding out why certain strains of mice were resistant to viral infections and another strain wasn't. And to his great amazement and surprise, he found it was related to interferon. So even though he tried to escape the effects of studying interferon in London, he nevertheless returned to it when he was in Switzerland. And it's also a very important lesson of why it's notwithstanding one's prestige in medicine and science, it's important to keep up to date. He was a classical biologist and was trying to find the gene that causes interferon by breeding mice. He didn't believe in molecular biology. And it's a pity that he spent his life trying to do that when one of his graduate students returned to the laboratory of Dr. Weissman in Boston. They synthesized the gene using techniques of molecular biology in about 2 months. So he was scooped by that too. And as I said, he died about just 75 years ago. So it's sort of an anniversary issue of his passing. But nevertheless, we now can group the interferons into 3 major groups, types 1, 2, and 3. Type 3 is very similar to type 1. They are types 1 and 3 are the types of interferons that respond to viral infections. Type 2 are the immune interferons. They're more involved with lymphocytic types of reactions to tumors. And we really are going to talk about the alpha and beta types of interferons, which are involved not only in virus reactions, but also particularly interest to us hematologists. Now, there is a huge family of interferons. There are at least 12 types of alpha interferons. There are many beta interferons, which have really not found much use in clinical practice. There is a beta interferon that's been tried in the COVID infection with variable results. And the alpha interferons, we've been recommending to our infectious disease people to use early in COVID, but the studies with interferon in preventing COVID progression or disease prophylactically, if you get a patient very early, has not really worked out systematically. So why are interferons of interest in the myeloproliferative disorders? Well, it was found that the interferons, particularly type 1 interferons, not only have anti-infectious disease effects, but they also have hematologic effects. And it was known that they suppress megakaryopoiesis. In the parentheses are the authors that discovered this. They antagonize the action of platelet-derived growth factor, which is very important, of course, in the myeloproliferative neoplasms. They inhibit erythroid progenitor development in vitro. They're anti-angiogenic, and angiogenesis, as we all know, is very important in the MPNs. They're involved in JAK-STAT signaling, and needless to say, that is an immediate clue that this agent is important because we have JAK-STAT V617F is so important in MPNs. And most recently, in the last few years, Dr. Anne Mullally, our colleague in Boston, has shown that interferon affects the PV stem cell, and thus some of the aforementioned effects that have been described over the years, which attracted me to the use of interferon in PV back in 1988, that it affects the PV stem cell by activating these dormant cells, beginning their cycling and then leading to their exhaustion. And in great distinction to other agents, particularly hydroxyurea, which we believe over the long term is leukemogenic, interferon is not leukemogenic, and it's perfectly safe to use during pregnancy. Now, that's very important because the current label by the FDA is incorrect, and I don't understand how that got onto the label because it said that interferon, which was approved by the FDA, should not be used in pregnancy. We find it's very safe to use. We've never had any problem with it either in our pregnant women with PV or with an essential thrombocythemia, and is in fact a drug of choice. So the issue of this new drug, ROPEG interferon, I would like to put in perspective. There, excuse me, there have been 3 types of pegylated interferons commercially used. The first was PEG interferon alpha 2B, and I mention that because ROPEG interferon is also an alpha 2B. So that is an interferon of the type 1 interferon alpha, but they're subgrouped as subtyped, as you can see, A, B, C, etc. And that relates to very small molecular changes, which really are not important clinically. But PEG interferon alpha 2B was first manufactured by Schering and then by Merck, but no longer. It had an unstable urethane bond between the pegylation and the interferon molecule, and that led it to hydrolyze rapidly, and it had to be given about twice a week. Now, I didn't find that to be particularly difficult, because when you think of a diabetic injecting himself with insulin 4 or 5 or 6 times a day, people seem to find that injecting oneself subcutaneously twice a week was an issue. I never found that to be true, but that was considered a disadvantage. The PEG interferon alpha 2A or Pegasus, manufactured by Roche, had a more stable amide bond and therefore a longer half-life, prolonged plasma concentration. It was thought to have prolonged efficacy because of its ability to maintain higher blood levels over a longer period of time, but and less toxicity. But all of these are suppositions. There have never, as I mentioned below, there have never been any randomized controlled clinical trials. I'll get to that in just a minute. And now, however, Pegasus was never licensed by the FDA. In our country, where everything has to be approved by an insurance company, it was very, very difficult for a nurse to try to spend hours on the telephone getting approval by the company. Over the years, it became less and less as more and more papers showed the superiority of interferon, we believe, over Hydrea. But the companies wanted us to use Hydrea because it was cheaper. Patients took it orally, it didn't require injections, etc. So rho-PEG interferon is a monopegylated interferon. That is to say that both PEG interferon alpha 2B and 2A have 11 forms of interferons in their mixture. It's a mixture of 11 isotopes, whereas rho-PEG interferon has only one isotope, and it's monopegylated, and it's linked via a proline bond, and it is thought to be presumably less toxic, but no one really knows if that's true or not because there have been no controlled clinical trials. And as I said, it's now commercially manufactured by AOP, Orphan, and Pharmacenture. I'm sure it will become soon to the Middle East. Now, it's very important to recognize there have been no randomized clinical trials in hepatitis C comparing any of these interferons. To the best of my knowledge, and I participated in this study, there was only one in chronic myeloid leukemia that was sponsored by Merck, by Schering at the time before it was taken over by Merck, comparing PEG-2B with Intron, which was a form of interferon you had to give 3 times a week. Again, the dosing was dependent upon the type of interferon. The side effects were all the same. And in that study, the short-acting interferon, which we gave 3 times a week or twice a week, was superior to the long-acting pegylated form. So there you go. That's the data. The important thing is when you hear about this from salesmen or company representatives, make sure, please remember what I've said, because there have been no qualitative differences between the interferons. It's a question of how often you have to give the injection. And it's very, very important to remember that the safety profiles are all the same. The side effects depend upon the dose and the intervals between administration. And many of the papers that report interferon causing significant side effects are because of the fact that the doses were too high to begin with. And we believe that one should start with a low dose, gradually escalate, rather than with a higher dose and coming down. So the dose with Pegasus that we start with in all myeloproliferative neoplasms is 45 micrograms a week. That's with Pegasus. And it's important to note that Roche is still manufacturing Pegasus, but it's off-label now. Again, in our country, that's very important because it means an insurance argument, which is very time-consuming. Whereas rho-PEG is now FDA approved, and the insurance companies have to reimburse the patient for that. And that's given once every 2 weeks, and sometimes even once a month when the patient stabilizes. So the side effects we must emphasize, they depend on dose. They're usually the side effects you get with a virus infection. That's why I emphasize the virus aspects of interferon: pain, headache, sometimes nausea, fatigue. They will respond as the dose is either lowered or with analgesics. They diminish over time. And are not of particular significance from the standpoint of patient care. More importantly, are some of the more significant side effects seen in patients treated with interferon, including autoimmune disease, hemolytic anemia, rheumatoid arthritis-like diseases. We have even seen myocarditis, rarely, one patient, optic neuritis. So it's not a drug that should be used casually. It must be used under the care of a person who's experienced with its side effects and with its malignant potential. Since the MPNs are diseases of older age folks, we're very concerned when patients develop evidence of peripheral neuritis, not uncommon among that population, whether or not they receive interferon or not, but certainly a common side effect with interferon. And that means that we always have to check the vitamin B12 and folic acid levels before we start interferon treatment, make sure that the patient is not predisposed to getting pernicious anemia by virtue of a low B12, and make sure the folic acid B12 levels are within normal range. Most of the patients that we have seen have developed evidence of neuritis when they do as a side effect of interferon, but we have had patients that we've discovered to have early pernicious anemia. So that's a bedside clinical point that's worthy of emphasizing, since basically, although we're hematologists and translational scientists, we're still physicians at heart. So one of the most important papers at the meeting were those that have shown that PV has significant effects on survival. And by virtue of introducing that, I'd like to show some data from Taher in a Blood article in 2014. He mentioned that compared to normal survival, expected survival, PV patients have a significantly reduced survival with a median survival time of about 14 years, shown in the lower left-hand curve and emphasized by this gray configuration that I've shown to emphasize this difference. Now that's 8 years ago, but what is even more disturbing is that Salver et al. In a paper in 2019, again from the Mayo Clinic, showed that there had been no improvement even up to 2019. And most of those patients had been treated with Hydrea. And now I would like to submit some data that was presented at ASH that indicate that patients with polycythemia vera have a much improved survival. So normal life expectancy for polycythemia vera in patients is possible. That comes from our institution. It was an oral session. And what we did was to look at 470 patients from my methods of artificial intelligence, which I'll talk about in just a minute. The shortened survival in PV is due to potentially fatal thrombosis, progression of myelofibrosis, and acute leukemia. And as we all know, treatment with aspirin, attentive phlebotomy, and cytoreduction can prevent thrombosis. And phlebotomy is the treatment of choice for so-called low-risk patients, i.e. those under the age of 60 with no history of thrombosis. And high-risk patients are those with a history of thrombosis over the age of 60. It's unknown whether available treatments can achieve a normal lifespan for PV patients. And our objective was to assess the extent by which PV alters overall survival of patients receiving available treatment, including interferon, which we have been using for a good number of years. So we compared the demographics and survival data of 470 adult patients from our center using methods of artificial intelligence from 1974 to 2020, all of which were diagnosed according to the PVSG study group or World Health Organization criteria, and compared that to the NCI SEER program. The median overall survival of the wild Cornell PV cohort and the SEER population was 26 years at Weill Cornell compared to 13 years for the PV cohort, PV SEER cohort, respectively. But these groups differed by age and sex. And when we corrected for that, the overall survival of PV at Weill Cornell was 11 years longer than the PV SEER data and matched by age and sex. And excess late mortality was observed in PV after 17 years due to increase in myelofibrosis progression rather than any other cause, affecting almost 50% of our patients. And in the next few slides, I'm going to explain what all this means. So on the top curve is the expected survival. The solid line is the expected survival of patients in the age group that we are addressing. In the lower red line is the SEER. That SEER data is the data you collect from Medicare statistics. You look at hundreds of thousands of patients with polycythemia vera and correlate that with your own data, adjusting, as I said, for age, sex, etc. And you can see that the PV SEER data, if you have polycythemia vera, you had a survival close to what was reported by the Mayo Clinic. On the other hand, the green line is the Weill Cornell data, and you can see that it was very similar to expected survival for up until about 8 years when it began to diverge, as shown by the green line. But nevertheless, and compared to the SEER data, which had a survival of 16 years, very similar to the 14 years reported by Mayo Clinic, our data showed in a significant number of patients that it was close to 27 years, nearly a 10-year difference. That, ladies and gentlemen, is a significant figure. So this is the reason why there is a substantial difference between our data and the SEER data. In the lower left-hand corner, the time in years, you can see that there's a sharp break in the survival curve, and that is because patients with polycythemia, their initial cause of death, as we all know, is thrombosis. Thrombosis is responsible for the initial cause of death in patients with polycythemia in about 20 to 30% of cases. Following the first 3 years, there is a continual threat of thrombosis, but that initial thrombotic event is diminished considerably. At about 8 years, you can see, as shown in the green line, the incidence and cause of mortality and morbidity is not thrombosis, but rather development of myelofibrosis. And acute leukemia usually, but not always, develops in the bed of myelofibrosis. This slide shows that myelofibrosis develops irrespective of whether a patient is considered a low-risk patient by ELN or European Leukemia Net criteria, National Cancer Community Network Center criteria or not, or whether they're high-risk patients on the same basis. And to remind you, low-risk patients are those under the age of 60 with a history of thrombosis, with no history of thrombosis, high-risk patients over the age of 60 or history of thrombosis. So myelofibrosis occurs in both risk groups equally. And this indicates that those risk categorizations that are being used around the world are probably out of date. This slide shows that if you look at the survival of patients treated with interferon, they have a survival almost equal to those of normal. And then you can see that up to 13 years, the survival time of patients with polycythemia vera is equal to those of patients of a normal patients without any polycythemia whatsoever, with a median overall survival of 28 years. And then we begin to see patients at about 24 years of follow-up beginning to develop myelofibrosis, and then their survival time at 30 years or 28 to 30 years becomes less than normal. So here is a dramatic difference in survival time between what was reported and what we now can find using a different technique of treatment. So we conclude that overall survival of patients can be significantly improved with available therapy in an academic medical center with an improvement of 10 years in overall survival. Excess early mortality is due to cardiovascular events can be reduced, but there remains excess late mortality due to progression to myelofibrosis. That's what needs to be prevented. And interferon may prevent or delay myelofibrosis progression, and PV treated with interferon have an overall survival. Our patients treated with PV at Weill Cornell had an overall survival similar to matched controls without PV, suggesting that normal life expectancy is possible with available treatment. Now, the next important point was that PV patients respond better to Ropeg alpha than conventional therapy. This is a very important paper by Gisslinger from Austria, because the question came up as to whether or not interferon is a better drug than Hydrea. This was a randomized trial by my colleague and friend Heinz Gisslinger, and this study really led to its approval in Europe and the subsequent influenced the FDA in the United States. This was known as a proud continuation trial. We initially had shown that change in spleen size was possible with interferon, whether or not patients received Hydrea. And in 30 patients with initial splenomegaly, 90% or 20%, 27 patients showed greater than 50% reduction in spleen size, whether or not they had received prior hydroxyurea. This was not a randomized trial, and that more than 75% of the patients, the spleen became non-palpable, and you can see how dramatic these changes can be with interferon. So that this indicates that if you have a patient treated with hydroxyurea, the next step is not necessarily giving him ruxolitinib, but rather interferon, because you can get dramatic responses, as we pointed out way back in 2006, but no one paid attention to us at that time. So Dr. Gisslinger did this controlled trial. He found that on the left is the key points. High rates of complete hematologic response were sustained at 5 years in those patients who never received hydroxyurea to begin with, or those who received hydroxyurea pre-treatment. Those are shown in the gray bars on the left. You can see those responses were sustained at the end of 5 years in the gray bars compared to the red, and that the control arm was lower in hydroxyurea pre-treated patients, and similar responses were found molecularly when you compared interferon compared to hydroxyurea patients. In the right part of this PowerPoint slide, you can see the gray bar, a significant change in the hydroxyurea treated patients, where there's a less significant change in the interferon bar shown in the right. So the conclusions for this study is there a high hematopoietic and molecular response rate to Ropeg were observed in both the Hydrea pre-treated and naive patients, as well as those with a high baseline JAK2 burden. And although early initiation of Ropeg is thought now to have a greatest disease-modifying benefit in patients with PV, these data suggest that Ropeg alpha 2B is a suitable treatment option in patients switching from therapy with Hydrea and in those with more advanced diseases. And so my comment is, don't rush to ruxolitinib, which will not have a qualifying significant biologic effect on the patients with PV, particularly if they haven't developed myelofibrosis, whereas interferon may. So the next important paper is rusferimide, which is a mimetic which is a heparin mimetic, which I want to talk about, a very interesting concept. It's now in phase 2. This is a ASH presentation of rusfertide, which is a ferroportin analog antagonist. And these investigators took PV patients who had more than 3 phlebotomies a year with or without cytoreduction therapy and used this hepcidin mimetic, a ferroportin analog antagonist, to maintain a hematocrit less than 45% in a 24-week period prior to enrollment. It was self-administered and compared to patients who maintain, and the comparison of proportion of subjects who maintained hematocrit control without phlebotomy. And this was the outline of the study, a very simple outline, giving the drug, then randomizing to phlebotomy or not, then discontinuing the drug and seeing what happens thereafter. And on the left, you can see in the dark spots, they don't show too clearly in this reproduction, patients requiring more than 3 phlebotomies every 3 months. Then the drug is given, and then there is an absolute reduction in the rate of phlebotomy in patients who were treated initially with phlebotomy only. And this could be translated into patients who had been treated with phlebotomy plus hydrea, phlebotomy plus interferon, and phlebotomy plus Rux. So this is a way of eliminating phlebotomy requirements in polycythemia vera. Obviously, it is a very interesting drug because we know that phlebotomy still requires a patient to go to a hospital. It takes a day to get there and back. There are some side effects with respect to using the needle. There's loss of work, etc. And also this drug, interesting, and it has not been explained as yet, corrects the severe iron deficiency that's been seen with phlebotomy because ferritin values raise and MCV corrects. That is to say, the iron deficiency seen in the mature red cells seem to be corrected. That has not been clearly explained by the authors, particularly Ron Hoffman from Mount Sinai. But a very interesting drug to keep your eye on because this can really change the outlook of this disease. So in summary of the encouraging results in PV, publication by Babu, in Lancet Hematology showing benefit of early ROPEG compared to phlebotomy in low-risk patients. That was not presented at ASH, but I'm just putting that in historical perspective. Improved myelofibrosis-free and overall survival in patients with interferon is significant. Interferon after hydroxyurea is beneficial, as shown by Dr. Gislinger, and rusfertide, the hepcidin mimetic, is a very interesting phase 2 drug, a very exciting presentation, and looks very promising in our patients with PV. So my time is, I'm a little over. Dr. Agarwal, am I running over?
So there's no problem, continue.
Okay, thank you. So I just want to talk about primary and secondary myelofibrosis. There was really no breakthroughs. There have been studies suggesting that ruxolitinib does lead to improved survival. In my opinion, that's case selection. I have never seen, I consider myself a histomorphology of some excellence. Not to be immodest, I developed a bone marrow biopsy some 50 years ago. So we review all our own biopsies at Weill Cornell. I've never seen a biopsy that has shown really significant improved hematopoiesis after ruxolitinib. I think, nevertheless, there's no question that it has a role in treating patients with myelofibrosis, obviously. because of the symptomatic improvement, the fact that it has such effects on JAK2, 1 and 2, and its effect on other cytokines leading to improved appetite control. And the new direction will be use of it in combination. In the United States and Europe, Rux and fedratinib are approved. Fedratinib is a good second-line drug after ruxolitinib failure or resistance. It causes responses that last about 6 months to a year, so that we still need other drugs for definitive cure of patients with advanced myelofibrosis. And as you know, pacritinib is still pending in the United States for patients with platelets less than 50,000. Momelotinib is also a drug for patients with anemia, and that has specific effects on patients with anemia because of a different pathway, which we won't discuss today. But as I said, the new goal is combination therapy. Now, there were a lot of drugs presented at ASH, and I find it very tiring when I listen to it. So I'm going to summarize these. And the most important, I think, is the BCL XL inhibitor of navitoclax. And there are new phase 2 and phase 3 randomized trials. This is a drug worthy of keeping your eye on, because there's no question that in combination with Rux, we have seen some significant responses. We have had this drug on the trial at Cornell, and there's definitely patients who have responded beautifully to it in combination, who have been resistant or intolerant to ruxolitinib as a single agent. There are drugs that have been used for targeting hematopoietic stem cells and microenvironment, a drug known as CD123. Again, phase 2, there are drugs affecting the TP53 pathway. I've already mentioned idasinutlin, a drug with too much GI toxicity. And then there are various drugs targeting fibrosis, cytokines, epigenetics, and other pathways, which already are in phase 2, but nothing that has really been of significance, in my opinion, except 2 that I'd like to mention. One, luspatercept, which is a TGF-beta inhibitor. It works by affecting erythropoiesis post the development of the nucleated red cell. And it seems to work in about 30% of patients with MDS and myeloproliferative diseases, particularly myelofibrosis. And it will be approved very soon in the United States. And then there's another bromodomain inhibitor known as pelabresib, which has been used in advanced myelofibrosis, which leads to amelioration of anemia and improved platelet counts in some patients, an interesting compound in a new post-transcriptional pathway owing to bromodomain inhibition. And then we have an alanine inhibitor, LSD1. Pentraxin is an older drug, still kicking around. We've never seen good responses to that. The LSD1 inhibitor, bromodestin, is one that may have some promise. So telomerase is a drug I have never found good responses. The end result is overall survival. And I have never been impressed with the marrow responses with this drug. We have not used it. Oral kinase inhibitor have not been shown to have much significant effect in advanced myelofibrosis. So just to give you the fedratinib data, 150 patients, intermediate and high risk. And as I mentioned, 6 months spleen and symptomatic reduction in 50%. And again, it's a small improvement because the effect lasts only 6 to 8 months. And then we want to mention the triple negative MPNs are a very bad prognostic sign. They're negative for JAK, CALR, and MIPL. Dr. Van Schenk, as you know, who found JAK2 in Paris, said, well, if you look hard, you'll find next generation sequencing abnormalities in this disease. And that's absolutely true. We have found that, and he's reported that in blood. But nevertheless, from a general clinical standpoint, these are considered triple negative. They are characterized by more severe disease, shortened survival, more epigenetic mutations, and decreased response to therapy, including RUX. So when we find that, we try to get them into remission as soon as possible and go to transplant. Which brings me to my last point in the myelofibrosis category, suggestions for treatment of myelofibrosis and accelerated blast phase disease, which remains very, very, very inadequate, is that you should do cytogenetics to make sure flow cytometry and molecular testing in patients who have blast counts more than 10%. Whether it's accelerated phase or full blast phase doesn't make any difference. We try to induce some type of reduction in spleen size and remission using hypomethylating agents such as azacitidine, and try to make them a transplant candidate insofar as possible. And if they have a FLT3 abnormality or an IDH1 and 2 abnormality, as you know from our colleagues in acute leukemia, which you'll hear about, they have specific drugs for this, and we use those drugs in those patients who have these demonstrable abnormalities. But our results have been so poor, I don't really want to talk about it. Lastly, there's an open label trial that is accruing in Asia, as you see, China, Hong Kong, Japan, Taiwan, accruing very poorly in Canada and the United States. I don't know if it's open in India or not, but these are for patients who are hydrea resistant or intolerant, and this ROPEG is being introduced as a drug trial in patients with resistant ET. Very hard to accrue such individual patients. So in summary, I think we have made a lot of progress in the past 5 years. Obviously, we always, as humble physicians, and we always must be humble, we have much more to learn. It's of interest that there was a far more patients, more studies presented and patients and abstracts presented on the MPNs and CML. It just shows you how the shift goes and over the years. The most important therapeutic aspect, I think, is an approved interferon in Europe, US and Western Europe. It's not unique. I want to emphasize that. The company may suggest that they are. It's not. They have fewer side effects. I think the phase 2 studies with rusfertide, this Herceptin mimetic, hepcidin mimetic, is very interesting. 2 more drugs likely to approved in Europe and in the US, namely momelotinib and pacritinib. Combination chemotherapy is the way that things are going. We need some fundamentally new agents. I've described some, but none have really made a significant impact as yet. And a large study of ET to determine if interferon is approved together with an would be of significance, because it would add another therapeutic agent to eneglide and hydroxyurea, which is a standard therapy for ET. I thank you very much for this privilege. I hope I've been able to contribute to this wonderful Congress. Thank you very much.
Thank you, sir. That was fantastic. So much of learning. You put in so much of information about interferon. Your statement about mental block in taking interferon injections when you can take insulin was fantastic. Then you talked about the improvement in the survival of polycythemia vera patients to near normal with the data from WCM. That was phenomenal. And the newer drugs, rusfertide, combination therapies. We enjoyed learning all this. This was a lot of new information to we people on this world. We have some of our colleagues who would like to ask some questions to you, starting with Dr. Aditya.
Good evening, sir. Thanks a lot for a very informative talk. So my question is, how commonly do you see secondary malignancies in patients who are on long-term hydroxyurea?
Well, that's an excellent question. The question is how often you see secondary malignancies with hydroxyurea. There is no question that squamous cell carcinomas are particularly significant in Caucasians, and there's no doubt about that because even the folks who like to use hydroxyurea a lot, namely the Italians, have admitted that at 5 years, the incidence of squamous cell cancer is about 5%. Correct. I take that 5. I don't know why I said 5%. The incidence of squamous cell cancers is significant, as well as basal cell cancer. So, particularly in fair blondes and blue-eyed Caucasian North Americans, we're very careful in monitoring their skin. And now I have followed the practice of having them see a dermatologist because, you know, in the United States, there's a lot of litigious activity. And if someone gets a skin cancer during the course of therapy, they can sue the doctor. So we've always had the patients followed by a dermatologist. Yeah, as far as solid tumors go, I'm not aware of any distinct I'm not aware of any distinct solid tumor that's increased in hydroxyurea-treated patients other than the skin cancers I mentioned. The big issue is hydroxyurea. And Dr. Barboui, who's my colleague and friend, would suggest that hydroxyurea doesn't cause increase in leukemia. And he cites his ECLAP study. Now, if you look at the ECLAP study, which I have done many times, you'll find that patients were treated for only a median of 3 years. Hydroxyurea will not cause an increase in leukemia in 3 years. It's a drug that has a cumulative toxicity, and you begin to see the incidence of acute leukemia at 10 years. And by 10 years, there's about a 10% increase of incidence of leukemia in hydroxyurea patients in our experience, which is fairly significant. And the French reported the same. And by 15 years, it's about 15%. Now, Dr. Jean-Jacques Kaladjian of Paris reported in Blood a number of years ago a comparison of hydroxyurea and pipobroman, which fortunately is not available in the United States. It is still available in Europe. And they reported that pipobroman caused even more leukemia than hydroxyurea. But in those patients treated with hydroxyurea, there was a 15% increase incidence of acute leukemia in hydroxyurea patients. So in my way of thinking, over the short term, hydroxyurea is okay, except for skin cancer. You can't use it for pregnant women, of course, because it crosses the placenta. And then it's a cumulative risk that you will find as the patient is treated and as the patient gets older. So we have in our institution, as you can see from our data, we've tried to abandon the use of hydroxyurea. Excuse me. I don't know how often you see secondary malignancies in India. What is the favorite drug in polycythemia in India? Hydroxyurea?
Yes, it is.
And do you see skin cancers in?
No, on an average, Indians are dark skinned. We don't see much of the skin cancer.
Right. Of course, hydroxyurea also causes, as you know, that ulcerative lesion in about 3% of patients, that vascular lesion So that's another contraindication. We have, of course, educated our dermatologists because they usually appear at a dermatologist first before they see the hematologist, particularly in the community. And that's another significant lesion, that vasculitis, an ulcerative lesion that forms over the malleoli. And that takes a long time to heal. So, we really don't like hydrea.
Yeah, and we do see a lot of ankle ulcers, dryness of the skin, breaking of the skin, oral ulcers, some GI. Yeah. So
Plus oral ulcers.
True. Yes, Dr. Aditya, another question?
Sir, my next question is again pertaining to hydroxyurea. So if someone develops ankle ulcers after the use of hydroxyurea, so apart from switching the therapy to, like, let's say, interferon, so what is the best management for hydroxyurea related ulcers?
Do you have, excuse me, is interferon available in India?
We have PEG interferon.
PEG
is not there.
Well, I show the data, which I think PEG interferon is not I think PEG interferon is the drug that should be used, because as Dr. Mullally, as I showed you from Boston, showed, and it's been confirmed by Radek Skoda from Switzerland in megakaryocyte stem cells, and we think the megakaryocyte is probably the cell that causes the fibrosis in ventral fibrosis and PV. But that interferon is a drug of choice because there's a biological basis for its use. That's why I showed that introductory slide, because I wanted to put the findings in perspective, so that hydrea is a non-specific cell poison. It affects DNA synthesis, as you know. It has no biologic basis for its use, so that's why we don't use it. In the patient who develops an ulcer, who requires therapy, we have used interferon primarily. Another drug, and particularly in older patients over the age of 65, it didn't originate with me. It originated with the British and the Germans. I think busulfan is a very good drug in low dose, 2 milligrams 3 times a week. Busulfan has a very bad reputation because it's an alkylating agent, and of course, all alkylating agents can cause acute leukemia. But in low dose, it's an easy drug to use. It has no side effects. It doesn't cause skin ulceration, doesn't cause skin cancer, can cause, in high dose, 6 milligrams, 8 milligrams a day, it can cause, over a period of time, 5 years, acute leukemia. So like all alkylating agents. But in a patient who's 70, we've used it, or older, we've used it routinely. It's a very smooth drug to use, and it shouldn't be forgotten, and it's very inexpensive.
Sure. Thank you, sir. Dr. Prashant.
Sir, very good morning for you, sir. My question is regarding the intermediate and high-risk myelofibrosis. In India, of course, transplant is not an option for a lot of the patients. And I've tried a lot of the patients, and again, ruxolitinib is still expensive. Very few patients can afford that. So I've tried a lot of patients on pegylated interferon. It works very well, but after some time, because of the cost factor, patient doesn't want to continue with that. So in that kind of situation, where do you place these hypomethylating agents in the therapy, sir?
Well, that's one, as an interferon enthusiast, there's one stage where we never use it, and that's in intermediate 2 and high risk myelofibrosis, because when the marrow becomes fibrotic, it really doesn't work. So it may reduce spleen size, but the doses that you have to use, we believe quality of life is very important. So as physicians, we're not just scientists. I think quality of life is so important that the doses that were used have been used are too high to maintain a good quality of life. So when we see a patient with intermediate 2 or high risk, as I said, we try to get that patient transplanted, but our results with transplantation, and I went over that quickly, is because they're terrible. I think there are more people making a living doing transplant for patients than patients are surviving. We have big transplant programs. It keeps them busy doing, we keep asking our transplanters, why don't you summarize what you've done? And it's very hard to get the data because they don't have any. I'm being nasty. I mean, they're trying to do the best they can, but transplant at that stage of the disease is really tough. So I think where transplant comes up is if you see an early patient, not the typical patient, but the early patient with age 50 who has a match and has got intermediate 1, then we're very keen on transplanting that patient. And we have a number, as does everybody else. And I think those patients do very well. But the number of patients who you can get into a treatable, because don't forget, the marrow is fibrotic. The spleens are big. They're anemic. They're thrombocytopenic. I mean, I think we're asking too much. I think we're assuming the impossible when we think we can get those patients in a good enough shape to transplant. And then you transplant them, and it's a horrible way to die. For me, I wouldn't do it. For myself.
What about the hypomethylating agents?
So the hypomethylating, yes. So we use azacitidine. There's an oral pill now, or IV, and we have discussions which is really more effective. They're supposed to be equally effective, but our people these people are so sick, they're usually in the hospital. And when in the hospital, they give them azacitidine, and then they get the counts down. But, the marrows, it's in the marrow. They never look at the marrow. Even in our own institution, we're very marrow-oriented. But you've got to do a bone marrow. Well, you've got a very sick patient. Then the patient says, must I go through a bone marrow? The doctor says, okay, you don't need a bone marrow. But, you don't get many marrow remissions. It's not like treating acute leukemia or CML, just isn't. That marrow is scarred, it's fibrotic, it's got a lot of collagen. There's nothing there. They usually have big spleens. I mean, I think at this stage in our knowledge that transplantation of high-risk patients with myelofibrosis is asking more than we can deliver, honestly, in the best of hands. And we, when I say best of hands, we're not the best. I don't know what the best is, but we're good. There are a lot of good centers in the United States, Cornell, Columbia, Sinai, MD Anderson, Stanford, but nobody's talking Chicago. Nobody talks about their results.
Thank you, sir.
Because there aren't any.
Thank you. Lovely. Dr. Khungar has a question.
Thank you, sir, for that providing excellent information about MPNs. Sir, I have one question. What is the pathogenesis of increased severity in case of triple negative MPNs? What is the pathogenesis?
What is what?
Triple negative MPN do badly. Why? What is the pathogenesis?
Oh, I don't know. Excuse me. I don't think anybody. Well, as I mentioned that in passing, Dr. Van Changer, who, as you know, is our great authority on this, the MPNs, because he did discover JAK2, feels that if you do enough high-level sequencing, you will find an abnormality in DNMT3A or TET2 or JAK2. One of the variants, JAK2 is V617F. You may find it as JAK V617FA, or, I'm not a molecular biologist, but a variant of this 617. We don't do it routinely because you really need a special research laboratory. Our molecular biologists will go so far, but only so far. So I think, and that's been reported. I mentioned that. That's been reported in blood, those variants, and you can look that up in the literature. The fellow in Austria, who's very good from, it's on the tip of my tongue, he's a very, very well-known molecular biologist. Anyway, he reported it too. So if you look hard enough, you'll find these epigenetic abnormalities, but not in the same consistency that we find JAK, MIPL, CALR. So they call them triple negative because if they just haven't been demonstrated in a routine, very good next generation sequencing laboratory. So we find them if we push our molecular biologist, his laboratory, he'll look up to a point, but he's not running a research laboratory. He's not particularly interested in MPN, so he stops. But with Van Schenker, that's his laboratory, so that's why he finds them.
Thank you. One of the questions from the audience is, if a patient responds to interferon, later on, can you reduce the doses?
Oh, that's a very, very important therapeutic question. And the answer is absolutely yes. and that is consistent with our using the lowest possible dose to keep the patient in clinical remission. We don't necessarily follow the JAK levels because that can be very variable. So we're a clinician. We follow what's the patient, how is it affecting the patient, and of course, what's the blood count. In PV, we want the blood. We absolutely agree. This didn't arise with Dr. Balbui. This idea of the hematocrit under 45 with a normal red count arose with John Pearson in England and the old polycythemia vera study group, where they insisted that that's where the blood is no longer abnormally viscous. That's why it's a target dose. He just confirmed it. But this idea of maintaining a hematocrit 45 or less has been well known since back in 1970. So if the hematocrit is maintained by interferon, and you don't need phlebotomy, because if you have phlebotomized patients, they become iron deficient. And we don't believe that phlebotomy under any circumstances is the way to treat any patient, because they become iron deficient and you get all the symptoms and problems with iron deficiency, including fatigue, difficulty in mentation. There's mitochondrial abnormalities, and most important, it affects the heart. So you can get patients with severe anemia with refractory heart failure. If you look at the 2015 How I Treat Polycythemia Vera by my colleague, Dr. Vanucchi, in blood, he was treating a dentist with a normal hematocrit, but the doctor couldn't practice his dentistry. To me, that's a failure, because we want a patient restored to normal quality of life insofar as possible. Now, when you cannot avoid phlebotomy with interferon, you must phlebotomize a patient, because if you have a patient with a hematocrit of 60, you cannot expect hematocrit to be brought down by interferon alone. You must phlebotomize the patient. Interferon will maintain the hematocrit, and most importantly, over a period of time, a year or two, the mean corpuscular volume and ferritin values will rise. So you end up with a normocytic, normochromic patient in remission. Then you can start lowering the dose to maintain the dose. Now, we find that if you discontinue interferon, that those patients tend to relapse. And then that means you got to start phlebotomizing them again, because we believe the most important thing in treating a patient with polycythemia vera is to have the hematocrit under 45. However, Jean-Jacques Kalajian in Paris has a number of patients who he has stopped treating because they have undetectable JAK2 levels, and they have had sustained remissions without interferon. We reported in Hematologica just 2 years ago that if you look at the marrows of those patients, they still remain hypercellular. So that it's not only the JAK that's important, but what's going on in the bone marrow. And we find that those patients who have a low JAK but a hypercellular marrow tend to relapse sooner. And then you have to start retreating them. So I don't think it affects their survival, but it affects their quality of life. You have to start in phlebotomizing, you have to start in, having them come to the clinic more often. It's a quality of life issue. I don't think that, but for sure, we want to get the dose down to the side effects down. I mean, the dose down insofar as possible to the lowest, to maintain quality of life, patient in remission, hematocrit under 45, platelet count under 600,000, preferably 400, and normal lifestyle.
Thank you, sir. Another question from the audience is, what percentage of patients do not respond to interferon, and are there any response predictors?
Well, that's a very good question. So I should have mentioned that. I meant to. So over the long term, all patients will respond to interferon. The question is, many develop significant side effects, and what's the percentage? So initially, virtually all patients will develop some degree of pains and aches. But if you tell them in advance and you give them Advil, I don't know what you call, we don't use aspirin, but Advil is an antipyretic in the US. Do you use Advil, antipyretic?
Advil,
an analgesic, antipyretic.
So paracetamol and tramadol.
The tramadol, yeah. So if you use analgesic, they get over the side effects within a week or 2 or 3. But overall, about 20% of patients, 15 to 20% of patients develop significant side effects with interferon that you must discontinue the drug. This includes autoimmune phenomena. We've seen, as I said, autoimmune hemolytic anemia. We've seen 2 patients with myocarditis. That's significant. They all recover. We've seen optic neuritis. We have seen significant pains and aches, joint pain, fever, etc. So, however, if you look at the incidence of side effects from hydroxyurea in the controlled trials, they're slightly less than the side effects from hydroxyurea. So I don't want to give you the impression that interferon doesn't have significant side effects. I mentioned that. I didn't mention the percentage in my presentation. I should have. But they're slightly less than hydroxyurea. Hydroxyurea has side effects too. Mollifilosis, as was mentioned, cancer, etc. Aphthous stomatitis, the ulcers on the ankles, etc. I would like to ask you a question. So, if I may.
Yes, sir.
Did you like the idea of my introducing the subject, that the topics, rather than just giving a whole list of? Did you like?
It is a fantastic. You gave a very different angle to the subject. Otherwise, we keep listening to some stereotype lectures. So this is fantastic.
No, just to give you the background to what the abstracts and presentations were.
We enjoyed the way you did it. It was
Oh,
very,
thank
very enjoyable.
Because I listened to one from ASCO last year, and the guy just went through one after the other. It didn't make sense to me.
The way you got bored, we get more bored.
Pardon me?
You said you got bored reading them or listening to them. We get more bored listening to them.
Oh.
Oh, no, what you did was fantastic. I mean, I'm, you took us through the history and you took us through the research at Well Cornell. You gave us what you have been doing and what is changing the line of treatment of this disease. It's fantastic. I mean,
Well, thank you.
very, very creditable. And you put it all together and put it to us. It's so enjoyable and was so educative.
Well, thank you. Takes time.
I must pat my back for calling you as a speaker.
Thank you.
Yes. Any other question, please? If there are none, I think we thank you very much, sir, and have a wonderful day ahead. And
right.
There's an opportunity. We will again like to interact with you as often as possible.
Well, thank you for inviting me, and have a good night. We're just beginning our day here.
Thank you, sir. Thank you. Bye-bye.
Thank you. Bye.
Everybody, this lecture was supported by Novartis, and I thank them. And thanks to all the participants over here.
Thank you.
Bye-bye. We meet tomorrow then. Bye. Bye-bye, sir.
Bye.